All right, welcome back. Thank you. I'm pleased now to introduce our fireside chat around leveraging existing capabilities to share information, which will be moderated by Dr. Tim Pletcher, who is the Executive Director of the Michigan Health Information Network Shared Services, which is a public and private nonprofit collaboration dedicated to improving the healthcare experience, improving quality, and decreasing the cost of healthcare for Michigan's people by making valuable data available at the point of care. Dr. Pletcher is also an adjunct research investigator of learning health sciences at the University of Michigan Medical School. Please join me in welcoming Dr. Pletcher.
So thank you very much, Shelley. We have a great opportunity. We're going to spend some time talking amongst ourselves, and I'll introduce the rest of our panelists here. And then we'll have plenty of time at the end to field some questions. But this is a pretty illustrious group, so I've got them up here on stage, and so I'm going to take advantage of that first. So I apologize, but I promise we'll get you around to asking your questions. First panelist is Jitin Asnaani. He's the Executive Director for the Commonwealth Health Alliance. Jitin is really the founding director for the Commonwealth Health Alliance. He's cut his teeth with Athena Health in terms of the real-world EHR experience. And even in that capacity, he was really instrumental in helping launch Commonwealth from that platform. Some of you, we've had a lot of fire stuff. This is a fireside chat. This is not a ring of fire as we go on there. But Jitin was also pretty active in the original formation of the Argonaut Project. He did tour of duty, I guess, way to say it, maybe, with the Office of National Coordinator. And he's been at this interoperability space for quite some time. And we're super excited to have Jitin with us. Not your first visit to Michigan either. So next we have Marianne Yeager. Marianne Yeager is the Chief Executive Officer for the Sequoia Project. Many of you, Sequoia, Care Equality, Ehealth Exchange often get sort of commingled. And there is a fair degree of overlap. But the Sequoia Project is a nonprofit focused on advancing secure, interoperable, nationwide health data sharing in the U.S. They're really a steward for a lot of our national activities related to HIT interoperability. Many of us here in this room are connected to the Ehealth Exchange. And the Ehealth Exchange has a more than quadrupled connectivity, making it not only the first, but the largest public-private health data sharing network in the U.S. And Care Equality is now another almost household name for those of us in the HIE space. And last, but certainly not least, is one of our Michigan natives, Carla Smith, Executive Vice President for HIMSS. Michigan HIMSS is one of our co-sponsors. Carla is the Executive Vice President of HIMSS, which is basically global, focused on better health through information and technology. How many folks here are actually members or have been to a HIMSS event?
Thank you.
Okay. Yay. All right. Basically, not only is Carla a resident here in Ann Arbor, but she's a thought leader across the entire country with extensive experience in nonprofit management and really helping HIMSS mission and really becoming a sustainable and growing organization. She has a number of years of experience in the information technology field, with the 2/3 of it pretty much focused on healthcare. She's championed, and last year HIMSS had an event really looking at some public health opportunities. We had a co-event with the Connecting Michigan for Health. And again, all three of these folks have been kind of helping us push this rock up the hill to achieve nationwide interoperability. And so I'm gonna, and this is not their first day, either probably together or on stage, but So let's just start off with you, Jitin, and we'll go all the way along. So where are we? We've been on this journey for a long time. MiHIN's, this is Connecting Michigan 10, okay? Where are we?
Wow, that's an easy question to start with. So yeah, we've obviously been on a long journey, actually a journey that precedes my entry into this industry from the e-commerce and finance industry. And I'd say where we are right now is I think we're ascending the J curve is where we are in interoperability today. Certainly, we've seen this within Commonwealth, where the number of exchanges, the number of sites getting connected, the number of sort of experiences that we find from end users who are finding the benefit from interoperability and reporting a variety of different improved and positive patient outcomes and physician-patient interactions. I mean, all of those numbers from year to year, if you look at it, I've just presented those to my board about a month and a half ago. And they're a little ludicrous. I'm like, yeah, we just had an 11,000% increase in year-over-year data exchange. I'm not sure, what does that mean? It's almost ridiculous, but it's not ridiculous. If you've been in a startup before, which I have on 3 different occasions, it's actually just a function of the fact that we are starting to go up that J curve right now. We are starting to see actual exchange at a broad way nationwide. And I'm using Commonwealth as an example. It's a microcosm. There's a much bigger world out there than that. And having my experiences at ONC and at Athena Health, I've just seen that we keep, it feels like it's slow-moving molasses almost, because it's a very big ship we're all trying to steer. But it is moving forward. Where we were when I was at ONC, my term was a 2010 to 2012 term. And we hadn't even figured out a standard way to exchange a clinical chart at that point. Not that the standards that exist today are particularly great, but at least we have one. And now we're talking about how do we improve it, how do we make it better, how to make it discrete, and all this other great stuff that we know needs to happen. And by the way, will probably keep happening for a while, and I'm sure we'll talk about what's coming next at some point. But in the meantime, every year we can look back and say we hit a number of big milestones in interoperability this past year, and every year we see more and more exchange that is happening. What is still, if that's the positive side of reality, the flip side to it right now is that it's uneven. It happens in pockets. I mean, if again, I'm going to use Commonwealth as the sort of the microcosm I'm most familiar with. We have about 80 members across the industry, and about 1/5 of those are deployed members who are actually doing data exchange. And whether you look at that, either of those two numbers is small compared to the number of participants who need to be participating in healthcare. And I'm talking about, in my case, I'm talking about technology companies. And even those numbers are small relative to the hundreds of EHRs and other HIT systems, most of whom don't even know what Commonwealth or Care Equality or Sequoia is, or how these things are different, or are they different? Are they just the same name for different names for the same thing? No idea. It's amazing the degree to which we can live in a bubble in interoperability as well, and that's something that's a flip side of the progress that we made. That it still needs to be instituted, driven, broadened across the entire U.S.
Let's see. Well, where are we? I guess I'm pretty much of an optimist, and I look back at when the work that we support, which started as an ONC initiative, the Nationwide Health Information Network, and Kelly, we worked together on that circa 2007 and 8. At that time, think about how low adoption was for electronic health records. So to me, it's about recognizing the progression of efforts. So, the NHIN started as this fledgling activity supported by the government, and there were a handful of, maybe 24 organizations, HIEs and health systems interoperating, and, we became the steward of it. It moved to the private sector, and yes, it's grown tremendously, and actually I had to check with my team to check the stats. I think it's 120 million patients served, by 59 HIEs interconnecting, and more than half of U.S. hospitals and 70,000 medical groups and CVS Minute Clinic and Walgreens and DaVita, and it all sounds so fantastic. But there's so much left, to your point, that it's great progress for one network. But that one network is a big pocket in and of itself. And so if you look at where the industry has gone and evolved since then, there are organizations like Jitin's group with Commonwealth Health Alliance, and then other different types of networks evolved to get these small doc practices connected, and really looking at care equality as providing a consistent way to allow those networks and service providers to interconnect has been huge progress. And so we look at what it took to get the eHealth Exchange, 9 years to get to the stats I mentioned, which sounds great, but it's not ubiquitous, right? Care equality is able to get close to that in 2 years. So to me, it's an acceleration. And when the eHealth Exchange becomes an implementer, and those participants can exchange data with the participants in Commonwealth, and we have 94% of the market interoperating in a consistent and common way, that is within reach. So we're still on that uptick of the curve and getting the connections established, but then I think the conversation will shift to how valuable is the data. And I can't wait for that conversation, not because it's not good enough, because then we'll finally stop talking about the plumbing and we'll talk about what really matters, which is, for heaven's sake, make the data usable and helpful for me and my kids and for all of us, and that to me will be the turning point, and it's within 2 years.
So I'm going to join Marianne in her optimism. One of the things that I have been asked so many times by people inside of the health field and outside of the health field is, why is this taking so long? And oftentimes, I don't know about any of you, but oftentimes the example that's added on to that question that's posed to me is, it's so easy in banking. I've got my ATM card and I can use my app and take a picture of my check and deposit. What is so hard? What's taking you guys so long in healthcare? I got so tired of trying to dance around that question, I finally went back and I did all of the research. And I was happy to find out that banking didn't wake up one day and have interoperability. It took between the early 1950s until 1996, so 40 plus years, before we actually, as a nation of consumers, had interoperability, systemic interoperability in banking. So you then layer that kind of an experience, which is honestly, by everyone understands, it's much simpler to create interoperability in banking than it is to create interoperability in healthcare. And we have come a tremendous distance. I've been working in this field since the 1990s, and people, to your point, Jitin, just in the time that I've been in this field, people have retired after spending their career working on this, and tremendous progress has happened. HIMSS has been involved and a big supporter of IHE for 20 plus years now, and every year I have the opportunity to go to a room that's filled with 800 engineers of competing vendors and public health and HIEs, and they are sitting next to each other, shoulder to shoulder, for an entire week to actually create interoperability against certain use cases. Then you have the whole explosion of FHIR. You have the fantastic work that's going on in organizations sitting here today and the organizations represented here, and I see real progress and opportunity.
One of the things on the banking thread is they also had 100 years prior to that experience with the legal agreements for how to share money, because there was an absolute incentive to be able to move money around, right? And so not only did it take them a long time to sort of get to do very simple things of what's the balance in my account, can I have some more money out, but they also had years and years of pre-negotiating, okay, where's the interest, what happens on the cash flow, who's liable if that person's account. All of those details had been worked out on paper. Mm-hmm. And in healthcare, we really haven't had the same kind of pressure to share and the same kind of basically legal infrastructure to undergird the technology. And so we've had kind of a double whammy in trying to figure that out.
Tim, you're absolutely correct. That is one of the differences. Certainly another one is that there is a level of risk that can be absorbed in the financial world that can't be absorbed in our world. It's not a loss of money in our world, it's patient harm or patient death. So
or loss of privacy in a profound way. Yeah.
Or loss of privacy in a profound way. You're absolutely right. So there are these other nuances. Also, the cottage industry that has been the health sector. You mentioned about the small practices. They're still with us. There are many in this wonderful state and other states. So there's multiple reasons.
So my next almost obvious question is, and we can just repeat the same thing, is, okay, where are we going? Get out your crystal ball and tell us in 2 years what you think will be different. And then at the risk of saying things so you'll regret, where maybe in 5 years do you think, what are we going to be talking about in 5 years about this space? Are we going to be celebrating it? What are we going to be doing? So.
Sure. I'll take a step. Actually, I'm going to build off what Marianne mentioned earlier. So in the next 2 years, the work that Ehealth Exchange and Care Equality, Commonwealth are doing, what we're doing sort of organically as a full industry, as well as what we're doing in conjunction with the government, things like TEFCA, the information blocking rule, the promoting interoperability program that just came out as well. These things are going to push us to the point where hopefully, yes, 2 years from now, we will probably still be talking about plumbing. One of the things that, again, does strike me is I talked 2 weeks ago to an EHR, small EHR. They're only in about 25 states, and somehow still count as small. And they'd never even heard of us. And I'm like, really? So okay, okay. So are you participating in Sequoia? What's Sequoia? That's a tree, right? No, hold on a minute. And so I was talking to him and realized that okay, there really is unevenness. But I think by and large, we are going to be in a place where the plumbing is no longer an issue, and we are going to be seeing the influx of data. And I think we're already starting to see that for those who are ahead of the curve. Dr. Stefanovic, who gave a beautiful presentation here just about an hour ago, talking about the massive ADTs and other information that he gets, and that's when he's still not tapping into the world out there of social determinant information and other information he knows he wants to get. Understanding how am I going to actually process and utilize and take advantage of that data in a way that's scalable, that's available, that's scalable not just for the health systems like where he works, but scalable for the mom and pop provider that is still, at least what is it, a third and a half somewhere of all of U.S. healthcare. How do you actually, how do you actually make that happen? And it's very doable. It's absolutely doable. We do it in other industries all the time. Insights at the point of care, insights before the point of care is not some sort of myth. It can happen. But it needs the data to flow first. And I think those are the conversations we'll be having ever more intently 2 years from now. And 5 years from now, I have no idea what we'll really be talking about, but I will promise you that we'll be celebrating the work we've done so far, because at that point in time, we will remember that having more knowledge is always going to be better for us than having less knowledge, even if it's sort of a trudge to get from here to there.
2 years from now, I do think that the query for documents capability will be virtually ubiquitous, and that will start making real strides in improving workflow and the efficiencies around that. I just feel that that's an incremental progress that we'll continue to see. 5 years, wouldn't it be wonderful if we all agreed on what the top 3 use cases were that we wanted to implement as a country and had a coordinated way to facilitate that? That's where we need to go.
I'd add on to these great examples. A couple other ones that occur to me is patient matching, ensuring that I have a fairly common name. Just within where I normally go to have my lab work done, there are 8 other Carla Smiths, and through no intent of HIPAA violations, I've learned little bits and pieces about those other Carla Smiths, right? So patient matching. And tomorrow, Adam Culbertson, by the way, is going to be part of the agenda and has some fantastic things to report on that work in patient matching. And then I'll also go to something that Kelly talked about this morning around regulations, is making sure that we have the appropriate regulatory levers being switched, right? So that we've got the right carrot and stick approach, the right regulatory framework that then can support the private sector and the health field of moving where it needs to go.
Thank you. So I would just build on the patient matching. Probably not going to have a national identifier.
Don't need it.
Don't need it.
No.
What,
No,
what,
it's
do we, what do we think is going to happen to improve patient matching across the country?
You want to go ahead?
Well, we've actually been doing not just a study, but developed actual implementation level rules around the data used for matching purposes and recently expanded it to include pediatrics. So there can be substantive, we can get consistency on the data elements and the rules used for matching. You can get it up to close to perfect.
Close to perfect is
Right.
98, 99? What's
Well,
close to
the
perfect?
study for Intermountain came up that if there's a secondary identifier that's available, it can get up to 99.1%.
And what's, just for folks in the audience, what's the example of a second identifier?
Well, it would be a health plan ID. It could be a social security number. It's kind of interesting. I'm hoping actually that the conversation around patient matching will shift a little bit because there is some speculation of whether a unique patient identifier will be the solution, and I don't have the answer to that. Maybe it is, maybe it isn't. But being really grounded in the real world, and the practical reality is we don't have that, then what can we do to make it better? And so from our perspective, that incremental progress is going to be key because the current state of affairs is just not sufficient.
Right. The current state of affairs are not sufficient, and HIMSS does not believe that a unique patient identifier is prudent. It introduces vulnerabilities that are inconvenient at best, terrifying at worst, and that there is a level of sophistication in the technology and in information today to where there are different patient matching abilities that we can get to, yes. And again, like I mentioned, Adam Culbertson will be here tomorrow, so I definitely would listen in because he's done so much work on this.
Yeah, I would. I think maybe I'm somewhere in the middle of those two comments. I do agree that we have a lot that already exists today that we could be building upon. You know, we have a privacy and security committee within Commonwealth, no surprise, and we started examining this notion today in Commonwealth. For those who don't know, you actually give the provider and the patient the opportunity to match and link their records, including specifying that those records are or are not mine, and we persist that over time. So over time, your data out there actually gets smarter. And when you ask for your data, you are more and more likely to get only your data, and at any rate, you can only after you've done your physical matching process can you access the data itself, the clinical data itself, that is. And now we're trying to find out, but how do we get to the point where it's just completely touchless? I'm a provider. I sit down to my EHR or my HIT platform, whatever that platform is, and I see all the data for this patient that I care about, and it is the right data. And how do we do that in an automatic way? And one of the things you realize is it's a lot of layers to that onion or that parfait or whatever your favorite analogy there is. But one of the things you realize is that it's just an uneven. Again, it's just uneven in implementation of existing standard available in every EHR system, no matter how complex or how basic, and people are just not implementing it the same way. And we can do it. If you just started moving towards that direction, you would start getting better and better matching. If you start tackling some of the Sequoia project releases excellent paper on patient matching, which I encourage everybody to take a look at. One of the aspects of it is around data normalization within the hospital. And that is actually turns out to be a much more complicated problem, but to the extent that there are solutions developing that answer that, or that those gets remedied from the outside in, we are looking at a place where we will start asking the question, do we really need another national patient identifier, a national identifier, when we already actually have a few that we can potentially work with? Provided we provide the right sort of risk mitigation around it, because those identifiers already have risk issues labeled to them. So I agree. I wouldn't characterize a national patient identifier as a must-have, but it is what we do need to have is more dialogue nationally and more kind of pushing forward of consistent implementation nationally, so that we can get to the place where we're getting that same outcome, regardless of whether or not we actually do implement one.
So we, speaking for MiHIN, we absolutely don't believe you need the sort of universal national identifier that's the single source of truth, right? What we believe you need, and we call it Common Key Service in Michigan, is a way to bootstrap the entire process for cleaning up patient data and matching, and that you just need a starting point to be able to evolve everybody up to a level where they all have good matching, because you talk to folks with resources and their data is perfect, just perfect. It's all those other people's data that's a problem. But when you get to patient matching, whoever has the weakest link, that's how bad your match is, right? And so it's easy to keep your own data good. It's hard to match your data with somebody else, and they seem to forget that when they run their own stats. So a couple of you mentioned use cases. What are the low-hanging fruit use cases that you see for us to achieve nationally? Like where's the appetite that we think we can really take on? And feel free to, go in order or jump around.
I'll let you go.
Okay, thank you very much. All right, I'll go first then. So, both Marianne's organization's various initiatives, as well as Commonwealth Health Alliance, are already driving forward the notion of query and retrieve clinical documents for the purposes of treatment. Already doing it at substantial scale between the two organizations. We have, almost 30,000 live locations, so there's maybe more. Actually, I'm not even including Ehealth Exchange in that, so it's probably even more. So we have this huge kind of we already have fair national breadth where we could say, yeah, this is something we can incrementally keep pushing out further and further, and with a little bit of more tailwind from regulatory or sort of other market means, we should be able to make that just a national ubiquitous service that everybody can understand that they should be able to get. I'd say ADT notifications, that's another one where you can say, yeah, between the for-profit vendors who exist out there, the patient pings, the collective medicals, the audacious inquiries of the world, and many others as well as not-for-profit organizations who do drive such services, MiHIN, Commonwealth, Sequoia's initiatives, etc. There is probably already also a great opportunity for broad national coverage on that front as well, and it's relatively low risk, just given the amount of work that's being done in the ADT space as well. It's uneven. The implementations, again, are uneven, so you get an ADT from one place, it looks very different from another place, and you can do something with it, you can match them relatively well, but there's certainly more that can be done to make it cleaner, smoother, better interface, such that Dr. Stefanovic doesn't have to have a full-time FTE doing nothing but going through ADTs all day, right? We should get to a place where your EHR has the intelligence and the data itself is good enough that it can pop up the insights and help you to create those lists immediately and to get that person to do more valuable things with those patients who need the help, as opposed to just track them down.
This is a sidebar. On ADTs, and I think I'm on record of saying we really want to have a nationwide ADT infrastructure. I haven't seen the CDC present in that conversation. Are they present in your circles that you're in? Because I would think there's a public health opportunity there just as well as a care coordination.
Possibly. So
because syndromic surveillance is not that different than an ADT message.
It's not. So I think in terms of opportunities and use cases, and I'll get to the CDC, I think expanding the purposes for which query for documents can be used is not only low-hanging fruit, we have it. It's just not being utilized for payment and operations. So that's what will allow you to get into pop health management. And again, it may not be the long-term strategy, but some data is better than none, right? CDC, we've seen some biosurveillance. Electronic case reporting is low-hanging fruit for them. Their national networks exist. Why not overlay some additional types of data being shared? I think event notifications is another priority that's a use case Carrie Quality is working on, as well as patient level queries using FHIR, data level queries.
One place where I know that they're working not on ADTs, but is on immunization registry interoperability. That's been ongoing for 3 or 4 years now.
Yeah, they got to have immunization registries to talk to. I mean, we're fortunate in Michigan that Michigan Care Improvement Registry is pretty good, but I know we talked to some states where they have a journey just to get the data into a place. So
what's really interesting is that in the at least in the public sector, and my experience now is 6 years old, so maybe it's become better, although I doubt it. But at least at the time I was there, a fair chunk of change was spent through grants and so on just demonstrating something works. And so you would have this $1, $2, $5, $10 million grant of money to show that something works in a particular community or area. And the problem is neither does that money scale, nor do the learnings necessarily scale nationwide. And CDC being a consistently cash-strapped organization, probably across CDC, but certainly on the IT side, whenever I see grants coming out of CDC, I still see them focused on those types of things, and I look at it as like, wow, that's another waste of money, because you can tap into an eHealth Exchange or Care Equality or Commonwealth, and you can do an experiment across 50 states.
Yeah.
And yes, we can figure out how to make it controlled so that you don't, if you learn something that was not good, you've not actually created harm. But that's really easy to do, and that is. With that, you can actually chop zeros from the number and that is going to cost you, and add zeros to the impact that you're going to get. And so I don't know why some federal agencies, and the reason I started with a caveat is some federal agencies have clearly made that turn. So one of our members in Commonwealth is the National Cancer Institute, and they're looking at enabling submission to cancer registries and for cancer research by making one single connection. You know that connection that everybody makes, that the 10,000, 30,000 connect here and there and there? No, they just want to make one connection to Commonwealth, get the data for everybody nationwide, and vice versa, so that we can enable better cancer research and the like. Seems like a very scalable idea to me, and it costs them virtually nothing to do it. That's where we should be going, and so it is surprising sometimes to see some agencies not involved as yet, but maybe it's just a function of time.
Before we turn things over to ask folks for questions, I'm going to turn just briefly to TEFCA and common agreement. Where is this some folks in Washington's idea of something that's interesting, or is this going to really meaningfully affect the rest of us in a material way that we need to pay attention to?
I would expect Kelly to answer that question.
Kelly, I think Kelly already made that clear, but I'm asking all of you. I mean, okay. where we're doing stuff, things are happening, the government's here to help, but where are we?
We need the government to intervene on where we're hitting a roadblock. We do have a really good foundation of contractual infrastructure to draw from, to build from, and the language in CURES was quite clear: to develop or support Trusted Exchange Framework Common Agreement, and to not disrupt or duplicate efforts. So to me, that says we have a substantial amount of contractual and governance infrastructure to date. We've talked about it. The data sharing occurring at Commonwealth and eHealth Exchange and across all these things with Care Equality isn't by chance. It isn't just by a handshake. There's an infrastructure there of governance and contracts that we can use. We know where the barriers are, and the barriers are things that are outside of our control, and we need the government to help and lead in that. So I think there is an opportunity for TEFCA to be very effective and to extend and build. It's all the details, right? And there are a lot of questions, and there's a lot of noise. So to me, it boils down to having the right process: public-private collaboration, multi-stakeholder, open, transparent governance, having the right voices, having the ability for public input, and to finalize the terms, to finalize the agreement, and to make sure that we're not dismantling what we have, but we are building from it and expanding further. And that is a great opportunity. See, is that good? Okay.
Yeah, I'll add that. So if I were to just buy T-shirts which had a logo on it, my logo would probably say "I love TEFCA." Yeah, I know.
Don't buy that T-shirt. Just hold off on that.
Okay, I will tell my team.
I've got some team members who are probably making that T-shirt for you now, so be careful.
But seriously, so as we are expanding, so obviously, if you think about so eHealth Exchange is one of the older initiatives, and it's about a decade old, right? Whoop-de-doo. Commonwealth has been live for 3 years. Care Equality has been live for 2 and change. So we're talking about baby initiatives, and we've still got pretty great adoption among all those initiatives, right? But that being said, like Marianne said, we're starting to see barriers. One of the barriers I've alluded to a couple of times now is that just uneven source of awareness. And the reality is that outside of the top X EHRs, call them some percentage of the top 20, a lot of EHRs don't know whether or not to take the steps, and then their providers who they serve, who oftentimes depend on their EHR and technology vendors to provide education or funnel education some way, they're not aware either, and they don't know how to take the steps as well. And so when there's an opportunity for government to provide, whether it's a regulation or law or rule or whatever, but in some form provide a beacon that everybody can see, it helps, because that's what we need. We need more tailwinds to help drive the work we're already doing. To Marianne's point, the work's already being done. You don't want to like start it from scratch, but you can drive a tailwind to get everybody there. The second big barrier is, and I know I see this in my organization, and through talking to Dave Castle, who's Executive Director of Care Equality, I know he sees this in his organization. People freeze when they have too many choices. You ask a provider, how do you exchanging data? Well, do I join Care Equality? Do I do Commonwealth? Do I do Direct Trust? Do I do blah or blah or blah? Or do I join my state health information exchange? The answer is yes, by the way. Do I do X or Y or Z? And it's just confusing, and it's hard, and it's not their jobs. And I love the fact that TEFCA says, single on-ramp, go to the same place. Here's the minimum bar. It's not here where you may or may not know where the patient is. It's not here where you have to do massive pop health analytics, which your mom and pop shop may not be able to afford. It's somewhere here where you are guaranteed to know where the patient's records are, and you are free to go get them. For the following purposes, in the following circumstances. As crystal clear as it can be at a level that's actually implementable by everybody. And that's what I love about it. Now, to Marianne's point, lots of devils in the details, but I feel like I think TEFCA got the notions right. And now hopefully we as industry participants will help to drive it to the right place. But I do love the fact that we might actually get to a place now where the work we're doing with the support and in conjunction with regulatory efforts is actually going to get us to a place where we can actually see that 2-year vision and that 5-year vision and whatever comes beyond that.
What did the HIMSS community think
So,
about all that?
Yeah, sure. So HIMSS is favorably inclined towards TEFCA for the reasons that have been stated already, stated well. And we also completely agree, the devil's going to be in the details. Is it going to work well? We don't know. We don't know.
Haven't seen the FOA yet.
Don't know. Kelly said it very well earlier today. It's been repeated here. The importance of building on the collaborations that are already out there. That's just so pivotal. Certainly use the Hippocratic Oath, right? First, do no harm in the creation of this. Picking that RCE that's going to be hard for you. It could be hard because it has to require a combination of driven determination that, with a laser focus of we are going to go here, but with also a magnetic force attached to it that says, you can follow us, you can trust us, we know where we're going. And that the RCE, the leadership is actually listening. And that's a really magic bit of mojo that's going to be needed in here. And you've got different kinds of exchange that is already going on in organizations. You've got the network-to-network kind of exchange. You've got consumer-driven exchange. You've got provider-driven exchange. And while there are many collaborations going on, there are also businesses, and people have jobs, and their families are counting on those jobs. And so there is going to be some potential of some really fierce battles, right, to actually get us to the next level. So those are some of the challenges, but in general, I like how, Jitin, I like the words you used of that beacon. I think that is what TEFCA offers to us.
Look for those T-shirts coming soon to a booth near you. Let's take a few questions. We can't see from here, so.
Oh, you want some mics? There you go.
Just one of each thing. All right, if you guys can share.
You get to answer
Got one right here.
Oh, no, ma'am.
Thanks.
Hi, Mike Kelly with Trinity Health. The last 2 or 3 years, I've been spending my life on integrating Cerner to Commonwealth. So I think I used to have brown hair when the project started, but I'm concerned about the patient matching issue. I still think it's a problem that we're seeing. we're hooking into a lot of different states. We've been in Commonwealth in a lot of our different states, and we're still running into issues with patient matching. So I wanted to just offer my 2 cents that I still think it's an issue that needs to be looked in. The other thing I'm curious about, so we set up our systems so they automatically enroll the patient or try to enroll the patient as soon as they're admitted into the hospital, and we automatically query for documents. And so we're pulling in daily thousands of documents from Athena offices, other Cerner systems, Epic systems, from all over the place. But we have very little proof that people are actually using those documents. And so I'm curious what your thoughts are about how we increase adopting this technology with our providers.
Great questions. So first of all, on the patient matching question, actually couldn't agree with you more. It's been tricky if you've been, it sounds like you've been involved in Commonwealth from the very beginning of our go live process. So you've seen the very manual process we started with and our efforts to continuously make that more automatic, at the same time give more control so that a provider really couldn't, and patient eventually also can do more to decide what data should be shared and should not, and so on and so forth. And it's a process. It's a process of iterating there. And patient matching is not going away. It continues to be a topic, especially as now we try to make it a fully automatic process. It does raise questions. So we have 4 federal agencies and a dozen vendors and then several provider organizations involved in helping us to try to figure out how do we do this in a way that we are comfortable with the level of risk that entails and give people the controls to be able to dial up and dial down that risk. So there is certainly a ton of work that's happening on that front. In terms of the in terms of that experience for that end user and whether or not interoperability is valuable in the first place, it's a very interesting question. When we launched Commonwealth, we said that over time there are 4 things we'd want to prove. A, that people will be aware of it. Oh wow, I'm using all the wrong fingers. A, that people will be aware of it. B, that we can get some vendors to actually say, you know what, we're taking the leap of faith, we're going to deploy this out there and just get it in the hands of users. C, that those users will utilize it, and D, that they will find value out of it. And each of those steps require tremendous effort. And you kind of have to do all 4 at once, but you can really only focus on one every year. And last year, the big question for us was, are people really going to utilize this and pull in documents and take a look at them? And we were nervous as heck, to be quite frank, that after deploying to at that time, it was like 5,500 sites. And it's like, are we really going to get it now that we have 5,500 sites live? And at first, the results were sort of anemic. And over the course of last year, we just kept seeing the results pouring in. People are downloading more documents. All right, some of that's due to automatic downloads. Okay, so now what can we tell that actually says people are utilizing? And we started getting the stories, and we did some number of systematic studies that showed that when providers, for example, are seeing a new patient, then they are 6 times more likely to pull a document from outside of their own EHR, because no matter what the quality of that document, they are totally under-contextualized, and they know that they could use some data, however good the data is or not. And to Marianne's point earlier, the data is not great across all of the US. That's where we have a lot of work to do. But if the patient has chronic conditions, then they've been somewhere else that you don't have an eyesight into. And again, that's another condition. I don't have the number there, but it's X number of times they will actually pull out that data as well. And for the rest of the time, even if they're getting automatic downloads of documents, they're not super interested. So we started feeling validated. We started seeing our numbers certainly fly up, but we also started seeing the repeated stories about how providers are using it. And we also saw the converse. There are a lot of circumstances where a provider could have used it, but he knows that the piece of information he wants is buried on page 300, or 300 is kind of exaggerating, on page 80 of the CCDA somewhere, and he's just not going to bother. And that's true too. So there's some amount of work that has to happen in improving the data as well as improving the machine learning capabilities of the EHRs, and they all are, whether or not they call it AI, they are all starting to do that. And that process will definitely continue. In the meantime, one thing that the entire industry has done, because it's been hard, but also because we're a little bit scared, is tried to, we've never actually just tried to measure the value of interoperability. I think there's an ONC group that does try to measure, is interoperability happening, but nobody's just tried to measure the value. And we actually formed a committee that's starting to think about, how would you do that? Like, could we do something stronger than a survey? Something that's actually maybe in transactional that tells us whether providers are finding these documents valuable or not. Why can't there be, you go to Google Maps and or you look for a place and it tells you 5 stars or 4 stars or 3 stars. It gives you a rating of what people thought, and there's sometimes reviews. The typical Amazon experience. Why can't you do that in healthcare? Why can't you do that in a network? We're trying to figure that out. So we've just started on that road. It's probably a road that'll take a couple of years to get there. And we can uniquely do it because we are a network which has very good visibility into every transaction that flows across. Not the clinical data, but that it actually is flowing across and from whom to whom. And we're going to start trying to answer that question because it's about time somebody did. But in the meantime, we are at least starting to see the proof in the pudding, and we know it's still a journey.
I wanted to address the question around the patient matching. If anyone is interested in getting involved in thinking through the patient matching, HIMSS is going to be standing up a work group specifically around that about providing guidance on how to look at the various patient matching algorithms and make some sense out of all of them so that patients and clinicians can be testing patient matching algorithms across clinical and claims data sets. So if you're interested in getting involved, and that you can either give me your business card after the session, or my email address is very simple. It's csmith@hims.org, and we'd be glad to hear from you.
Carla, you said a couple of things that were interesting, one about the baking industry and the other one about your lab claims.
About what?
Your lab claims, there's eight other, yeah.
Okay.
So I think one of the other differences about the banking industry and the way healthcare works is that we own our money in banking. So it's really important to us as individuals to understand what's happening. And in this world, as we start evolving, looking at blockchain technology and integrating it into healthcare, I'm surprised none of you guys mentioned that in the next 5 years and the role that'll help play in solving the patient matching, making sure the right Carla Smith has the right lab values, and also helping simplify some of the things we do downstream. You guys have any thoughts about how blockchain is going to help improve what we do?
Sure. I'll take a stab at it. Oh, did you want to? Oh, okay. I'll take a stab at it. So blockchain, so I kind of think of blockchain as sort of 2 time horizons. We started looking at blockchain a year and change ago, and we asked ourselves, well, if we were to re-architect Commonwealth right now, would we re-architect it in a blockchain capacity? And we said, the chances are maybe we would. There's still, there's some degree to which blockchain is not fully proven. So, we'd have to ask ourselves, do we really want to do that? Would people trust us if we actually did that or not? But we're getting close to the point where we feel like we could say yes. The flip side we asked ourselves was, what problems would that solve? And what we realized was one of the key tenets of blockchain is this notion that the key that you use to be able to access the blockchain is also distributed, which with clinical data, it's not clear. In fact, it seems very unlikely that you'll be able to do so. So somebody will have to manage those keys. And if you go to somebody who is managing those keys, then what you have is centralized management of access to the infrastructure in the first place, which is what we have right now. So we looked at it and said, you know what, we're not there yet. It's not solving a real problem for us yet. That being said, like I said, that was sort of wave 1. Wave 2, or maybe horizon 2, is just more maturity of blockchain itself. We are starting to see applications of blockchain now in the payments side of healthcare, and where they deal with a number of the same issues, but their problems are very blockchain shaped. So it kind of makes sense for them to be applying the blockchain to it more so than on the clinical data front. So I think what we will see is that a future version of Commonwealth will be based on blockchain as well, because at the point of time that sort of wave 2 is now where we've seen enough maturity of blockchain in healthcare that we feel like clinical data, putting it there, would not be some sort of grand experiment with the lives of the 30 million patients that we have, that are currently connected to us, then we'll be really interested in participating there, because we have no interest in just staying legacy, in perpetuity. And we have plans for, and we have a pathway that gets us from one technology system to the other. It's not there yet because of those reasons articulated.
So I'll just make a blockchain comment. Blockchain is a good thing, yay. But there are components of the blockchain that make great sense for healthcare, but the traditional use, at least in my own mind, I'm still struggling to get my head around it. But one of the things that makes great sense is the ledger concept. Okay, that appeals to folks. But we don't want, we actually need to know the name of the patient. So encrypting and hiding things is confusing for us, because we have enough difficulty doing patient matching and figuring out where to go and connect stuff. But I think some of the principles of publishing information, writing to ledgers, is incredibly powerful. But one of the concepts that's missing in blockchain currently is this idea of a prospective ledger, or a prospective relationship. And so for us in Michigan, the 30 million or so active care relationships that we have, and our people kind of publish and write to our homegrown ledger, it is our poor man's blockchain that, as things go forward, we very much see that evolving toward probably the right fit of blockchain technology to what we're already doing. But I think it's, for those of you who know, there's lots of mining, and they waste a lot of energy actually doing proof of work around, should I trust that piece of the blockchain? In healthcare, we are heavily legal. We have lots of infrastructure to say, proof of stake, you guys are responsible for this population, and you guys are responsible for that population. So, I think there's a tremendous opportunity here, but I think it's in front of us, and I think it's building off of some of the basic, simple data components that we're putting together.
Sure. Helen Hill from SEMHI, the Michigan HIMSS, and the MiHIN board. Excuse me. As you look at use case development, I'm wondering if there's a thought about trying to bring clinicians of all stripes, physicians, nurse practitioners, folks from the FQHCs, and other settings of care into thinking about what the critical pieces of data are that help them do their jobs. Because as we found when we were looking at an initial Beacon grant, not everyone uses the same data. They just don't have the same uses for it, the same frequency. So, we're kind of in the age now of, as Mike pointed out, of the electronic version of the old dump truck that we used to come up to our clients with, thousands and thousands of pages of green bar reports. And we don't want to be there. We want focused, actionable data. And, the IT people can help facilitate, but they aren't the knowledge brokers.
I could not agree more. I think we need to fundamentally shift the paradigm for how use cases are identified and defined, and the litmus test should be clinicians, healthcare providers, and patients that define the requirements, and we should be implementing and assessing the efficacy and value of it from their lens, not ours.
Are there any more questions? Like I said, we can't really see from here. Well, with that, please help me thank our panel and watch these folks.